Imagine this scene. A surgeon successfully places a life-saving organ, maybe a kidney, maybe a heart, into someone who desperately needs it. From a purely mechanical view, it's incredible.
Absolutely, a feat of surgical skill.
But then, the moment blood flow is restored, the recipient's own body, this incredibly complex defense system built over millennia, doesn't recognize a gift.
No, it sees an invader, something foreign.
And that's the heart of the problem we're tackling today. Rejection of tissue transplants.
Exactly, it's the biggest biological challenge. The recipient's immune system identifies the new tissue, the graft, as not self, and, well, it launches an attack to destroy it.
So today we're doing a deep dive into that very conflict. We'll focus on allografts, which are transplants between people of the same species. That's pretty much all clinical transplant.
Right. Xenografts between species, that's more experimental for now. Allografts are the day-to-day reality.
We want to understand how the body even spots this foreign tissue. Look at the different ways rejection happens over time, sometimes instantly, sometimes slowly over years.
And explore the really clever ways we try to manage and prevent that rejection. It's quite a story.
It really is. So where does the immune system start? What's the biological red flag?
The main targets are proteins called HLA alleles, human leukocyte antigens. Think of them as your body's unique ID badge, present on almost every cell surface.
And these aren't uniform, are they?
Not at all. They are incredibly polymorphic. That just means there's a huge amount of variation in these genes across the population.
So between any two random people, the chances of having the exact same HLA badges are tiny.
Virtually zero, unless you're identical twins. They're the only ones who naturally sidestep this whole recognition issue.
Okay, so the immune system's T cells, kind of the field generals, spot these mismatched HLA badges. How do they recognize the threat? I gather there are two main ways.
That's right. Two distinct pathways, the direct and the indirect. And they really dictate the timing and the type of damage.
Let's start with the one that causes the most immediate trouble, the direct pathway.
Okay. In the direct pathway, the recipient's T cells directly recognize the donor's HLA molecules displayed right there on the donor organ's own antigen-presenting cells, or APCs.
So the T cells are patrolling the new organ and see the donor cells waving the wrong ID badge.
Exactly. It's a very direct confrontation. And this pathway is thought to be especially important for driving that fast T-cell mediated acute rejection. It's a strong immediate signal.
In the other way, the indirect pathway. That sounds more like how the body usually handles foreign stuff, like bacteria or viruses.
Precisely. With the indirect pathway, the recipient's own APCs cruise by, pick up fragments of the foreign HLA proteins shed by the graft, process them like any other foreign material.
And then show those fragments to the recipient's T cells. Standard procedure almost.
Right. But here's the key difference for you to grasp. Well, the direct pathway often drives that early acute attack. The indirect pathway seems to be a major player in the more long-term, smoldering damage, what we call chronic rejection.
It's fascinating that the response to an organ transplant is so much more, well, violent than fighting off a common cold. Why is that?
It comes down to numbers, really. The frequency of T cells in your body that are capable of recognizing these foreign HLA structures, these Alloantigens, it's just vastly higher. Orders of magnitude higher, in fact, than the T cells specific for any single microbe.
So it's not like a few specialist cells responding. It's like mobilizing a huge portion of the army just because the uniform is different.
That's a great analogy. A massive pool of T cells is immediately ready to react. This leads to the rapid activation of CD8 plus cytotoxic T lymphocytes, the CTLs that directly kill graft cells, and also CD4 plus helper T cells, which release chemicals, cytokines that fuel inflammation.
Okay, that massive response sets the stage. Let's break down the three main clinical patterns of rejection, starting with the most dramatic, hyperacute rejection.
Yes, hyperacute. This is thankfully rare now, but it's a true surgical emergency. Happens within minutes to hours, right after the surgeon connects the blood vessels and blood flow returns to the organ.
An almost instant failure. What drives that?
It's driven by preformed antibodies. These are antibodies the recipient already had in their bloodstream before the transplant even happened.
Where would they come from?
Two main sources, either natural antibodies against incompatible blood group antigens, which is why ABO blood type matching is absolutely critical, or antibodies against MHC-HLA antigens developed from previous exposures, like blood transfusions or even prior pregnancies.
So these antibodies are just sitting there waiting.
Like tripwires, exactly. As soon as blood carrying these antibodies flows into the graft's blood vessels, they bind immediately to the endothelium, the inner lining of those vessels.
And that triggers.
A massive uncontrolled activation of the complement system. It's a cascade effect, causing severe damage to the vessel lining, which leads very quickly to widespread blood clotting thrombosis.
The blood vessels just get completely blocked.
They do. The organ is instantly cut off from its blood supply, leading to ischemia and rapid tissue death necrosis.
What would you actually see if it was a kidney, for instance?
The kidney would rapidly become bluish, mottled, floppy, and stop producing urine almost immediately. Microscopically, you see blocked arteries, damaged vessel walls, and widespread infarction. Basically, the tissue dies off.
Sounds devastating, but you said it's rare now.
Yes, and that's a huge success story for pre-transplant screening. We prevent it rigorously through 2 steps, ensuring ABO blood compatibility and performing the crucial cross-match test.
The cross-match.
That test specifically checks if the recipient serum contains antibodies that react against the donor cells. If the cross-match is positive, the transplant generally doesn't proceed with that donor. This has virtually eliminated hyperacute rejection.
Okay, so we've largely dodged that immediate bullet. What about the next time frame? Acute rejection. This is more common, right?
Yes, acute rejection is the principal cause of graft damage in the early period, typically occurring within days to weeks after transplant. Although, importantly, it can flare up suddenly months or even years later if immunosuppression is reduced or stopped.
And this fight happens on 2 fronts, you mentioned, cells and antibodies.
Correct. We talk about acute cellular rejection, driven mainly by T cells, and acute antibody-mediated rejection, also called humoral rejection.
Let's take the cellular one first. Those T cells we talked about earlier are now attacking.
Exactly. The CD8 plus CTLs directly invade and kill graft tissue cells, while the CD4 plus helper T cells orchestrate inflammation by releasing cytokines. Looking under the microscope at a kidney biopsy,
What do you say?
you typically see lymphocytes infiltrating the tissue. It often follows 2 main patterns. One is inflammation primarily in the kidney's functional tissue, the tubules, and the space between them that's called the tubulointerstitial pattern.
Okay. And the other pattern?
The other, often more concerning pattern, involves the blood vessels, the vascular pattern. Here you see lymphocytes attacking the lining of the arteries within the graft. We call this endothelitis or intimal arteritis.
Why is attacking the vessels more concerning?
Because damaging the blood supply directly threatens the viability of the organ much more quickly. It can cause small areas of infarct and lead to more significant long-term scarring if not treated promptly.
But there's some good news here. Cellular rejection often responds to treatment.
Generally, yes. Most episodes of acute cellular rejection can be treated successfully, usually by temporarily increasing the doses of immunosuppressive drugs. That's our window to intervene.
What about the other side of acute rejection, the antibodies? Acute antibody-mediated rejection.
This one can be tougher. Here, the recipient starts producing new antibodies, specifically targeted against the donor's HLA antigens, particularly those on the blood vessel endothelium.
So antibodies bind to the vessels again, like an hyperacute, but it develops later.
Right. And again, they often activate complement. Pathologically, we look for signs of injury in the tiny blood vessels, like the glomeruli and the capillaries around the tubules. We call that capillaritis. We also look for evidence of complement activation, specifically deposits of a complement component called C4D.
And this step is harder to manage.
It often is, yes. It may require different treatment strategies, sometimes involving therapies, to actually remove the harmful antibodies from the blood, like plasmapheresis or drugs that target antibody-producing B cells.
Okay, so we've covered the immediate hyperacute and the early acute attacks. That leaves the long, slow grind. Chronic rejection.
Chronic rejection. This is the major challenge in transplantation today. It's an indolent, progressive form of damage that unfolds over months and more typically years.
And you said earlier, this is the one we haven't really beaten.
Unfortunately, yes. It's the leading cause of grafts failing in the long term, largely because it's quite refractory to our current immunosuppressive therapies. We can slow it sometimes, but we often can't stop it.
What's driving the slow destruction? Is it still the T cells and antibodies?
It involves both, yes.
Yeah.
There's a persistent low-level immune response. T cells, likely activated through that indirect pathway we discussed, react against the foreign HLA and secrete cytokines. Alloantibodies also definitely contribute to the vascular damage.
And what do those cytokines do over time?
They act as growth signals, stimulating the proliferation of cells within the graft that shouldn't be proliferating excessively, particularly fibroblasts, which lay down scar tissue, and vascular smooth muscle cells within the artery walls.
Leading to scarring and blocked vessels.
Exactly. The hallmark of chronic rejection, especially in solid organs like kidneys and hearts, is progressive graft arteriosclerosis. This isn't typical atherosclerosis with cholesterol. It's a diffuse thickening of the inner layer, the intima of the graft's arteries.
So the vessels gradually narrow?
They narrow, become stiff, and eventually get occluded. This slowly starves the organ of blood. Combine that with increasing interstitial fibrosis scarring throughout the tissue, and you get a gradual, relentless decline in organ function.
A slow strangulation, essentially. A really difficult problem.
It really is.
Given these challenges, particularly chronic rejection, let's talk about the strategies used to maximize graft survival. We touched on HLA matching. It's crucial for kidneys, less so for others.
That's broadly correct. For kidney transplants, getting the best possible match for the main HLA types, HLA-A, HLA-B, and HLA-BR, significantly improves long-term outcomes. So it's a major focus.
But for heart or lung transplants?
The priority shifts. Those organs don't tolerate being outside the body for long, so the urgency of finding a suitable recipient and minimizing the cold time often outweighs the benefit of waiting for a perfect HLA match. Matching is done, but it's not the absolute gatekeeper it is for kidneys.
So for most transplants, we rely heavily on drugs, the immunosuppression arsenal.
Absolutely essential. It's usually combination therapy. We use drugs like corticosteroids to broadly reduce inflammation.
Yeah.
Then drugs like mycophenolate and mofetil, which work by inhibiting the proliferation of lymphocytes, stopping those T and B cells from multiplying.
And the real cornerstones, the ones aimed squarely at T cells.
Those would be the calcineurin inhibitors. Drugs like tacrolimus and cyclosporine. These were game changers when they arrived.
You mentioned they block something called calcineurin phosphatase, which stops IL-2 production. Can you walk us through that again? It sounds key.
It is key. So for a T cell to get fully activated and launch an attack, it needs internal signals. One crucial step involves this enzyme, calcineurin. Calcineurin activates a molecule called NFAT.
NFAT.
The NFT is a transcription factor. Think of it like a key that turns on specific genes. And one of the most important genes it turns on is the one for interleukin-2, or IL-2.
And IL-2 is the fuel for T cell proliferation.
Exactly. IL-2 is a powerful growth factor for T cells. It tells them, okay, multiply, build an army. So by blocking calcineurin, drugs like tacrolimus prevent NF8 activation. No NF8 activation, no IL-2 production.
And the T cell response fizzles out before it starts.
Pretty much. It's a very effective way to dampen that initial T cell activation signal.
Are there newer approaches emerging beyond these established drugs?
Yes, there's a lot of focus on being more subtle. Instead of broadly suppressing the immune system, researchers are looking at ways to modulate it. A key area is co-stimulatory blockade.
Co-stimulation.
T cells generally need two signals to get fully activated. Signal 1 is recognizing the foreign HLA. Signal 2, the co-stimulatory signal, comes from interactions between other molecules on the APC and the T cell, like the B7 molecule on the APC interacting with CD28 on the T cell.
Okay.
The idea is if you can block that second signal, even if the T cell sees the foreign HLA signal 1, it won't get the necessary go-ahead to mount a full response. It might become inactive or even tolerant.
So potentially preventing rejection with fewer side effects.
That's the hope. More targeted immune control, less global suppression.
Which brings us to the inescapable downside of all this. The success comes at a cost, right? The risks of long-term immunosuppression.
A very significant cost. It's a fundamental trade-off in transplantation. By dampening the immune system to protect the graft, you inevitably lower the body's defenses against infections and cancers.
What kind of infections are we talking about?
Patients become much more vulnerable to opportunistic infections, bugs that wouldn't normally cause problems in someone with a healthy immune system. We often see reactivation of latent viruses like cytomegalovirus, CMV, or polyomavirus, which can actually damage the graft itself, particularly in kidneys. Fungal infections are also a risk.
And the cancer risk.
That's also significantly increased. Certain viruses that are linked to cancer, like Epstein-Barr virus, EBV, can cause lymphomas in immunosuppressed patients. We also see a much higher rate of skin cancers, particularly squamous cell carcinoma.
It sounds like a constant tightrope walk for the clinical team.
It absolutely is.
Yeah.
Always balancing the need to prevent rejection against the risk of infection or malignancy. Fine-tuning drug doses is critical and requires constant monitoring.
So wrapping this up for our listeners, the big picture is clear. Recognizing foreign HLA is the trigger,
Driven mainly by T cells.
leading to different rejection patterns. hyperacute, immediate antibodies, acute early T-cell antibodies, and chronic long-term fibrosis arteriosclerosis.
And our main weapon is immunosuppression, which works well, especially for acute rejection, but has serious long-term side effects and doesn't fully conquer chronic rejection.
Which leads to the ultimate goal in the field, something that sounds almost futuristic: donor-specific tolerance.
That's the dream, to train the recipient's immune system to accept only the donor organ's HLA antigens while leaving the rest of the immune system fully intact to fight off everything else. No need for global immunosuppression.
How could that even be achieved?
Research is exploring various avenues. Things like using regulatory T cells, TREGs, which naturally suppress immune responses, or more sophisticated ways to block those co-stimulatory pathways we talked about, aiming to induce that specific unresponsiveness just to the graft.
So the core dilemma remains: how do we protect the precious gift of an organ without crippling the patient's ability to protect themselves?
Precisely, it's the central tension.
And this brings us to our final thought for you to consider. As we look to the future, which path holds more promise for finally overcoming that stubborn hurdle of chronic rejection? Will it be achieving true specific tolerance, reprogramming the immune system itself? Or will it be the development of vastly better, smarter, non-toxic immunosuppressive drugs that simply manage the rejection without the current dangerous trade-offs? That's the billion-dollar question driving transplant research today.